is Dr. Ryan Guys. I'm one of the pediatric ophthalmologists and neuro-ophthalmologists at Boston Children's Hospital. And I am going to be talking today about retinopathy of prematurity. Uh, it's a topic that's near and dear to my heart and one of my most favorite things that I do. So I hope I can share that with you guys today. I have no financial disclosures. My goals for the talk are to review the current strategies for the evaluation of patients with retinopathy of prematurity and their management, to review the current criteria for screening and treatment options for retinopathy of prematurity, and also to review the updated classification system for ICROP, the International Classification of Retinopathy of Prematurity, the third edition, which was released just a few years ago. So I think it's always important to start with what ROP is, because the pathophysiologic underpinnings of it really kind of dictate how we screen and treat these patients. So it's the arrest of normal vascular development in the preterm infant with compensatory mechanisms that produce aberrant vascularization of the retina or neovascularization of the retina that can lead to blindness. The epidemiology is that it's the leading cause of preventable childhood blindness worldwide. In the United States, 80,000 infants are at risk of ROP each year, and approximately 1,500 have disease with treatment warranted retinopathy of prematurity. Worldwide, the incidence of blindness from ROP has been estimated to be about 32,000 patients per year. So here's our agenda. We're going to talk a little bit about the history, a little bit about the pathophysiology, classification, screening, and finally treatment, with some updates for 2026. So in terms of history, in the 1940s, was the first epidemic of what is now known as retinopathy of prematurity. Then it was called retrolental fibroplasia, and you could really see it on the exam without much trouble because it was right behind the lens and it was a retinal detachment. So obviously, at this point, it was no recovering of vision, and they really didn't have treatment options. And this is what you might see at the bedside back then. So that was in the 1940s. In the 1950s, the role of oxygen was elucidated in the development of retinopathy of prematurity. They were looking at various different causes, fluctuations in temperature, ambient light, pH, and oxygen. And finally, it was discovered that high oxygen levels were causing blindness. And unfortunately, it was also noted that high oxygen levels were really important for the survival of these children. And so that was the 1960s, is they realized that while they could cut down on the oxygen, they were having worse adverse systemic events. And obviously that's more important in brain development and other organs. And so it really was where a balance needed to be struck. And it was also very hard because there were really no treatment options at that time. In 1984, the first ICROP classification was released. And then in 1986, the cryo-ROP study demonstrated that we did have treatment methods, and if eyes reached a certain level, which at that time was called threshold, where you had either 5 contiguous clock hours of stage 3 or 8 total clock hours of stage 3 with plus disease, then treatment with cryotherapy would help improve visual outcomes, although visual outcomes were still not what we would want them to be today. And so with cryo, remember what you're doing is the same thing that you're doing with laser. You're basically destroying the avascular retina, or the cells that are producing the signals that are causing the neovascularization to grow. It's obviously very destructive. And then in 2000, the early treatment of ROP study came into existence, and really has revolutionized the way that we care for ROP, and is still the underpinnings of the way that we care and treat ROP today. So the idea of type 1 ROP was introduced, where we have a level of ROP where treatment was definitively better than observation, and type 2 ROP where treatment with laser versus the level of ROP that kids had, we'll get into what that is in a few minutes, was basically equivocal. And below that, the risk of treatment was actually greater than the risk of observation. And then in 2008, the BEAT ROP study was published, which introduced the use of bevacizumab on a wide scale for retinopathy of prematurity. And with bevacizumab, babies who are in zone 1 and posterior zone 2, but mostly zone 1, were found to have better outcomes with treatment. And obviously, there were some issues with this study, but as there are with every study, but it really was the first one that kind of brought it into the mainstream. And then in the 2010s, we started to have other studies looking at the treatment of ROP with anti-VEGF agents. So the ROP1 from PDIG was looking at lower dose Avastin and its effect on VEGF levels systemically, and also its ability to treat retinopathy of prematurity. The Rainbow trial, which was looking at ranibizumab or Lucentis, and finally Butterfly, which were looking at the ability of aflibercept or Eylea in the treatment of retinopathy of prematurity, and eventually led to in the United States, FDA approval, which is our Federal Drug Administration, so governmental approval for the use of Eylea or aflibercept for the treatment of retinopathy of prematurity, and that was the first drug that had been deemed so. So in terms of the pathophysiology, normal retinal development, the choroidal circulation starts to vascularize by around 6 weeks of gestational age. The retina becomes increasingly metabolically active, leading to physiologic hypoxia. The hypoxia stimulates VEGF, which with subsequent beginning of retinal vascularization around 13 weeks of gestational age. And here's where it starts becoming really important and really relevant to our clinical practice. Nasal retinal vascularization is usually complete in a term infant around 36 weeks of gestation. Temporal retinal vascularization usually completes by around 40 weeks. So this is kind of our benchmarks for when we're looking at premature infants, what to expect and when to expect. Every now and then they will vascularize nasally before 36 weeks. Sometimes their gestational ages are just off because remember, they're estimations. And sometimes they'll vascularize temporally before 40 weeks. Sometimes they'll take a lot longer if they have active retinopathy of prematurity and other systemic comorbidities. But it's important to know the normal vascular development and time frame so that you can kind of anticipate what's going to happen in the retina. And then there's always the question of gestational age, postnatal age, and postmenstrual age. So gestational age is measured from the first day of the mother's last menstrual period to birth. So when we talk about some of our children now who are nano-premature infants, they were born at 23 weeks gestational age. Postnatal age is how old they are chronologically. So James is now 11 weeks old. He's now 34 weeks total of postmenstrual age, but 11 weeks of postnatal age. And then postmenstrual age or PMA, James was 23 weeks gestation and is now a 34-week infant. And so this is kind of the language that we use to talk. So now that we know the normal retinal vascular development, it's really important to look at what happens in retinopathy of prematurity. So in utero, it's a hypoxic environment, and you have normal vessel growth, and you have normal levels of IGF-1 and VEGF. When you have premature birth, the hypoxic environment in utero that the child was in becomes hyperoxic. And once it becomes hyperoxic, then the signaling of vessel to promote vessel growth, the VEGF and the IGF-1 levels start to decrease, and vessel growth arrests. Then, as the retina starts to mature and become more metabolically active, it starts to send out increased signaling to help the blood vessels grow. And so here's where you get the spike in VEGF. And unfortunately, when you get that spike, not only do the normal blood vessels grow, but you also get retinal neovascularization. And this is what leads to retinopathy of prematurity. And either the retinopathy of prematurity will resolve on its own, which it does in the majority of cases, or it will end up become a proliferative retinopathy and lead to retinal detachment if we don't treat it. So here is a diagram from the BEAT ROP study that was published in the New England Journal of Medicine, and it can kind of take us along the way. So you see, around 24 weeks and and greater is when we have these NICU babies who we're dealing with, and they don't usually get examined until around 31 weeks of life in the United States. And at that point, some of these very, very young babies will already have retinopathy of prematurity, some won't. And so we're following them to see when they get to that level of type 1 ROP where treatment becomes warranted. And then obviously there are multiple different ways that we can treat now. So cryotherapy is still in existence, although not widely used in the United States. There's also laser therapy and bevacizumab therapy. Then now we would call it anti-VEGF therapy because we have three different agents that can be used and are used depending on your center. So classification. So the way that I think about ROP is zone, stage, and plus disease. The where, the what, and how bad is it, or is it bad? So in the zone, the where, here's the diagram that we typically use, and this is taken from the third iCrop study. So in the third iCrop study, what was introduced was this concept of posterior zone 2, which is just about in zone 1, a little bit further out, but still highly concerning. And the way that I look at this clinically is, and that you can tell if something is in zone 1 or zone 2, is if you can see the nerve in your 28 diopter lens when you're doing indirect ophthalmoscopy, and you can see the edge of the vessels, you're still in zone 1. The other way to do it is that it's twice the distance from the optic nerve to the macula if you're looking temporally, but that can also be a little bit hard to see and kind of map out when you're just looking in and the baby's obviously moving. RetCam photos can be really helpful for kind of figuring this out too, when you get a chance to. And then you can see the clock hours, and you can see that zone 2 is basically finished at nasal vascularization. So when I'm looking for zone 2 versus zone 3, the first place that I look is nasally. And if the blood vessels are all the way to the aura nasally, then the child is usually in zone 3, although temporally, the nasal and temporal retinas don't have to vascularize at the same pace. So it may still be in zone 2 temporally, although usually they're pretty equal, and they kind of tell the story together. So then we have the stage. And one of our fellows taught me this one, which is Dr. Fit, as a way to remember what the different classification is. So the demarcation line is stage 1. So you start to see that there is a physical difference. It can be hard to tell stage 0 or immature retina from stage 1. Stage 2 is where you start to see a raised ridge. So you could really kind of feel it. If you're running your thumb over it, you'd feel a bump. Stage 3 is where you get fibrovascular proliferation into the vitreous. Stage 4 is an incomplete or partial retinal detachment, 4A, where the macula is not involved, and 4B, where the macula is involved. And then finally, stage 5, which is a total retinal detachment. So obviously our goal is to prevent stage 4 and stage 5. So some pictures from the initial iCrop diagram, and then some pictures from the most recent iCrop to kind of elucidate what immature retina looks like. And so you can follow the blood vessels out, and you see at the edge of the blood vessels that there is just nothing there. The blood vessels just stop. And if you're looking at this, you can see the distance from the zone from the nerve to the macula, and then you can see twice that. So this is into zone 2. But really the blood vessels just stop, so there's nothing that we need to worry about. Once we start to see stage 1, this is more that ROP is present. It's still very mild, but you can see where there's a clear demarcation between vascular and avascular retina, and that's denoted by the white arrows. One of the things that iCrop 3 also introduced is this concept of the notch. So a notch is temporal. It is often right in line with the macula. And when we're classifying ROP zone, we will classify it by the most posterior zone that it is. So remember, everything's backwards. So anterior is far out in the peripheral retina. Posterior is more towards the back and the optic nerve. And what will happen with the notch is the notch can bring it back a zone. So this would be stage 1, zone 1 by notch, even though most of the vascularized retina appears to be in zone 2 or posterior zone 2. The notch, which is denoted by the black arrowheads, is clearly in zone 1 and near the macula. And so it is that most posterior area or zone that we label it as. And then stage two is a raised ridge. So you can, again, you see it, it's a little bit thicker. It's hard to tell in a picture, obviously, without being able to see three dimensions. But you can tell it's a little bit thicker. You can also start to see some little white pink circles that are in front of the ridge. And so you can see them right around there, right in front of the arrow. And that is some neovascularization that is posterior to the ridge. It's not touching the ridge. We call those popcorn if they're circles and hot dogs if they're cylinders. And that's a sign of disease activity, but it's not included in our either our treatment criteria or anything else. It's more just something that we need to know about because it means that the stage two is more active than if it wasn't there. And then finally, we get to stage three where treatment becomes warranted, which we'll talk about in a little bit. And so here at the white arrows, you can see that even though it's hard to tell in three dimensions, it looks like a wall of pinkish tissue. And then the blood vessels appear to be much more dilated and tortuous. So this would be plus disease and stage three. So this would be type 1 ROP that would require treatment. Um, Given the location, so it's in mid to posterior zone 2 based on the distance. So here's the nerve, and then the fovea is right about here. And then it's probably about here would be posterior zone 2-ish. And it's obviously not an exact science. And so depending on the age and other comorbidities of this child, you'd have a lot of treatment options at our institution where laser might be considered if the child was older, or injection if the child was more sick currently. It all depends on the situation that the child is in, and we'll talk about that a little bit more later. And then, unfortunately, when RLP is not treated adequately or quickly enough, it can result in things like this, where this is a 4A detachment. So you can see the fibrovascular ring. It almost looks like a scleral buckle inside of the eye, and it's raised. Fortunately, the macula is not involved in this child, so the vision would hopefully be somewhat preserved. And then you can get a 4B where you have a partial retinal detachment, but the macula is involved, and vision would obviously be greatly affected. And here's another incidence of a tractional retinal detachment. And then finally, if it continues to progress, it can lead to a total retinal detachment. And you can see it just like in that picture of the retrolental fibroplasia, and you can see it as a funnel on B scan. And so plus disease is the last kind of piece of this ROP classification of is it bad? And plus disease is part of the art as much as the science of retinopathy of prematurity, is there can be a lot of disagreement between investigators. And so what ICROP3 has done in order to kind of help us better describe plus disease is introduce the importance of the P-score, which I'll talk about in a second, which is essentially a grading scheme for plus disease. And I was fortunate enough to see Michael Chang from the National Eye Institute talk a little bit about this research. And what they found is that with plus disease, when even world experts will disagree on whether something is or isn't plus disease, especially if it's kind of borderline. So if you give any picture of some of these borderline plus disease patients to 10 experts, what they found was 6 out of 10 would agree that it's either is or isn't plus disease, but no more than that. So about 60%. That number goes way up when you start giving it a score and you say, is it better or worse than this image or that image? And so when there's a comparison, the ability of the experts to reach a consensus went way up, which is why the P score was introduced. And so here you have some pictures of the P-score, and they did a really nice job of just highlighting the blood vessels and also putting a color to it. So green, obviously meaning normal, and then you start to go from green to yellow. Yellow, so the top three pictures are P-scores 1 to 3. The middle three are 4 to 6, and the bottom three are 7 to 9. And so 7 to 9 generally is indicative of plus disease. 1 to 3 is generally not. 4 is generally not. 5 and 6 is where you start to kind of wonder, is it progressing? Is it active disease? Is there a retinopathy of prematurity going along with it? And so this idea that we have some comparative images has been instrumental in helping us better describe what we're seeing, in addition to RetCam photography and or fundus photos, I should say, because there are different cameras, and getting agreement amongst experts. The other thing that iCrop 3 has introduced is it changed the classification of what was known as aggressive posterior retinopathy of prematurity, or APROP, or Rush disease, if you for those of us who are a little bit older. So the change that was made was to call it aggressive retinopathy of prematurity, because they noted that depending where you are in the world and what your NICU care is like, you may have aggressive retinopathy of prematurity outside of zone one, which is the APROP definition was in zone one, and that it is important to know that it's different wherever you are in the world. And so the nice thing about retinopathy of prematurity is it tends to follow a cadence. So I know that children in the United States who are born between 22 and 26 weeks are at risk of developing this aggressive ROP. It usually is developed around 33 to 35 weeks. So I know in that time frame when I'm screening to be really attentive to this. And what you're looking for is plus disease that's out of proportion to the retinopathy that you see. So you'll often see very dilated and tortuous vessels like you do in this picture, but you won't really see any three-dimensional neovascularization, because the stage 3 is actually inside of the retina itself. And so it's really important to be able to recognize this, because it comes on very quickly and can lead to retinal detachment very quickly. Here with the white arrows, you can see that kind of junction between the vascular and avascular retina. And one of the hallmarks of this aggressive posterior, so in the United States posterior, but aggressive retinopathy of prematurity, is that it tends to skip stages, meaning that we don't see the development of the stage 3. It doesn't go from 1 to 2 to 3 like older children do. It just tends to immediately go to 3 and kind of explode very quickly. And here's another example of it. And so you can see this flat neovascularization, that can be very tricky to deal with, and is one of the places where anti-VEGF agents, and we'll talk about their benefits later in the talk, have really come into effect and been very helpful. And this zone 1 disease is what the BEAT ROP study demonstrated as being especially effective, anti-VEGF agents being especially effective in treatment of. So screening. So who gets ROP? The two main factors for getting ROP that we've discovered are low birth weight and low gestational age. And so if you look at the cryo ROP study and the ET ROP study, the percentage of babies that got ROP was much higher the lower the birth weight was, and much higher the lower the gestational age was. And at the time of the ET ROP study, less than 27 weeks was, a fairly early child. And now in the United States, we're starting to save 22 to 24 week infants. I even have one 21 and 6 week infant, who required ROP treatment. And so the younger you are, the higher the risk of developing retinopathy of prematurity. And the lower your birth weight, the higher the risk of developing retinopathy of prematurity. And then in terms of onset, so in cryo-ROP and ETROP, stage 1 was typically developing around 34 weeks, and then treatment level ROP was developing around 36 to 37 weeks. So that was the past. And it's important to know that these studies were done in the United States. So this is the retinopathy of prematurity that we see. It's not necessarily the retinopathy of prematurity that you see, because it really does depend on the balance between NICU care, eye exams, etc. So it may be slightly different, and it's why it's important to, especially with some of these screening algorithms that we have now, like WinROP or GROP, they're wonderful, but it's very important to make sure that they're validated in your patient population, because if they're not validated in your patient population, they may lead you in the wrong direction. So in the United States, the birth weight and gestational age that we typically screen for is less than or equal to 1,500 grams and less than or equal to 30 weeks. And so 30 weeks and 6 days is considered requiring treatment. Dr. Nimesh Patel at Mass Eye and Ear has done a lot of work looking at what he calls the two-ROP strategy, meaning if you don't meet criteria for one of these criteria and you're going to get screened, but what is your risk of developing ROP? And it's generally very, very low. At Children's, when we validated his idea, we actually only had a handful, like one or two children that ended up requiring treatment who were only positive for one of these two screening criteria. And they had retinopathy of prematurity by 37 weeks, so they obviously were caught. But it does beg the question of is there a way that we can start screening less babies and more and because there is some morbidity with the exams that I don't like them. They can cause bradycardia and desaturations and things like that. In Canada, they're actually a little more loose in their criteria, so they actually screen 1,250 grams or less instead of 1,500 grams. And then the criteria worldwide varies, and it varies depending on where you are and your NICUs, because obviously kids may be older but more at risk. And here's that question of WinROP and GROP. So what they incorporate is postnatal weight gain to help reduce the number of screenings. And it's just very important, again, to make sure that they are validated in your patient population before you use them. One of the ways that we're considering them too is that there are some babies who are outside of our screening criteria who would have become positive by GROP, for example. And so we may be missing babies that develop retinopathy of prematurity that needs treatment a handful each year across the United States. And so that's one of the questions that we're going to hopefully try and tackle when we work with the American Academy of Pediatrics for our new screening guidelines. The more premature an infant is, the longer the time to develop severe ROP, meaning if they're 22-weeker, we still screen them around 31 weeks. What our studies have shown at Children's is that it's not that they develop more severe ROP earlier than that. It also can be very hard to look in and see because the vitreous tends to be very hazy. But it's rare that we're seeing a baby for their first exam and treating them on that exam. And then one of the things I wanted to talk about was telescreening, which is something that we're doing a lot more at Boston Children's right now and across the world. So traditionally, obviously, screening has been in person, but there are some benefits to telescreening. It really does improve access to care. So there are some places in the United States and across the world where there aren't ophthalmologists who are skilled and trained to screen for retinopathy of prematurity, or there aren't enough of them. And so by telescreening, you are looking at pictures. You're looking at the posterior pole mostly, but we can get further out depending on the skill of your photographer. And you're looking for treatment warranted ROP that would indicate the need for a referral to a center that will treat for retinopathy of prematurity. And it has been demonstrated to reliably indicate treatment worthy retinopathy of prematurity. It's particularly good for trying to find plus disease. There are some drawbacks to it, though. You obviously can't see the whole retina into zone 3, or it's very challenging. So babies cannot really be graduated from screening or transition to the next phase of their care, which is follow up with a pediatric ophthalmologist for regular vision checks and strabismus and amblyopia evaluations until they've had at least one outpatient exam. It can be harder to convey the importance of screening to patients and families since there's no direct contact. So one of the things that we're able to do is when we're rounding in person is to explain why we're doing what we're doing and how important it is and the risk of blindness. And sometimes, given how many problems most of these babies have and how many subspecialists are involved, it can be hard for the NICUs to convey every detail about every subspecialty problem. And one of the things that we've noticed is that the importance of following up can be a little bit harder to convey that. It can be a little bit harder to convey that message. The equipment is expensive for the NICUs. I know there are some smartphone cameras that have been trialed and written about, but the ones that we use in the United States, the RedCam itself is several $100,000 to purchase. You need speculums, you need multiple camera lenses to try to prevent infection, et cetera. which can be hard. And then the larger and older babies are obviously much more hard to image because they don't want to be held down. So the image quality can degrade as they get older. When we're doing telescreening, it one of the other negatives is that it often requires some additional exams for babies. So when I'm seeing a baby in the NICU and I see that, even if it was a 24-weeker and I'm seeing them at 31 weeks and they're immature in zone 2 already, and I got a great view, I will give them 2 weeks for a follow-up. When they're being telescreened, since you can't always see to the edge of the vessels, you're often giving them weekly follow-ups, so they're getting extra exams. I typically high risk babies or if retinopathy of prematurity is present on the image, will be seen weekly. Low risk babies, so I use the Digirop, DIGIROP screening algorithm. You can find it on the internet to help kind of risk stratify. It's nice because all you need is the birth weight and gestational age. There are other variants of it too where you can take into account the degree of retinopathy prematurity or whether there was ROP in the last exam. And that, if they are very low risk for developing type 1 ROP, then I will often screen them biweekly to try to give them a little bit of a break. And these are obviously babies that are older and larger. And then older children who are higher risk but without ROP, you can space to biweekly. Dr. Moshfeghi from Stanford, who's long been a proponent of telescreening, has published a study in ophthalmology retina within the last 2 years that demonstrated that babies who are over 40 weeks who did not have retinopathy of prematurity or severe retinopathy of prematurity did not progress after 40 weeks as long as they were stable and could be moved to biweekly screening, but still requiring these exams. And again, they're harder and the children are larger. So now we've kind of defined the problem. The next question becomes, how do we treat it? And these are kind of been the major advancements of the 21st century and 20th century, but 21st century, since that's where we are now. So this diagram, we talked about when to treat. So this is where type 1 ROP comes into play, and we'll talk about it in a little bit, but type 1 ROP, meaning stage 3 in zone 1 without plus disease, stage 1 or 2 in zone 1 with plus disease, or stage 3 in zone 2 with plus disease. And so these are what we use to determine whether a baby should be treated or not, because treatment has been shown to improve visual outcomes in those patients. And then which treatment modality we choose, we're fortunate enough to have both at Children's, and so we try to tailor it to the baby. So this is a picture of what threshold would look like from cryo ROP. And so, as I mentioned, they define threshold as 8 non-contiguous clock hours of stage 3 or 5 contiguous clock hours of stage 3 with plus disease. So obviously something that would be treated quite aggressively now. They would wait even longer, and also they really only had cryo at that point. So that was their only treatment option. And they found that in eyes with threshold disease, this leads to a 50% chance of retinal detachment if left untreated. Although it's interesting that it was not 100%. So some of these babies still did regress. With cryotherapy, you are ablating the avascular retina. So you're destroying the cells that create the VEGF signals that are causing the retinopathy of prematurity to get worse. The problem is that just like with laser, while you're destroying those cells, there's still VEGF signaling in the eye itself, and it takes 1 to 2 weeks for that VEGF signaling to kind of peter out and be washed out. And so you can still get progression of retinopathy of prematurity even after treatment with cryo or laser. And so we don't really use cryo in the United States anymore. And so here is that current treatment paradigm. So pre-threshold type 1, like I already talked about, and then pre-threshold type 2, which the ETROP study demonstrated the outcomes to be equivocal whether they were treated or not, was zone 1, stage 1 or 2 without plus disease, and zone 2, stage 3 without plus disease. I like to put an important caveat into type 2 ROP, which is the one specific type, which is the zone 2, stage 3 without plus disease. If there is significant stage 3 temporally, which is right in line with the macula, so 2 or 3 clock hours or more, that stage 3, as it starts to regress spontaneously, can still lead to traction. So it needs to be watched very carefully, and in some cases may warrant treatment that's a little bit earlier, depending on the condition of the baby. So it's just important to watch out for the potential for develop traction. With treatment, usually laser, because these kids are older, it just helps the neovascularization resolve faster. And using the ETROP treatment paradigm, structural outcomes improve. So the presence of bad structural outcomes decreased from 15.6% to under 10%. So type 1 ROP is treatment indicated. Type 2 ROP is follow closely within 1 week. So often type 2 ROP patients, depending on how they look, I may see twice a week, depending on where they are and how they're progressing. And so here's again that picture from ICROP3 of a patient who would clearly have type 1 retinopathy of prematurity. And then, as I mentioned, so we have a couple of different treatment options. We're not really using cryotherapy anymore, but we are using laser and anti-VEGF injections. And here's why. So these are pictures from the BEAT ROP study. And so you can see a baby who was in zone 1 with type 1 ROP and was treated with conventional laser therapy almost up to their fovea. And you can see all of the retina that was ablated. And how this is obviously going to severely constrict their peripheral vision. This was fortunately a good structural outcome, though, because the retina remains flat, but the level of vascularization is never really going to increase beyond where the laser took place. Versus a child who received bevacizumab, and then you can see with the white arrows in the second image, the smaller arrows, that's where the old demarcation line was, and you can see that the level of vascularization doubled at 13 months. So what I tell parents when I'm recommending anti-VEGF injections is that one of the major benefits of this is that the retina will still have a chance to grow, and it will help improve the amount of retina they have to see. I also talk about how the anti-VEGF agents, when we inject them, immediately bind to the circulating VEGF and therefore tend to start working within 24 to 48 hours. What I've noticed more recently with aflibercept injections is that the babies who are most active, who have type 1 ROP in zone 1, who have such a high burden of VEGF, that the anti-VEGF agent tends to work much faster because of that. And then the older babies where less VEGF is circulating, it tends to be a less kind of dramatic effect. But you can see in that picture on the bottom in frame C, where if you were to laser this patient, you then have to wait 2 weeks to see it take effect. And it can be a very harrowing 2 weeks as the ROP may progress given the VEGF that's signaling versus the injection where it takes it away immediately. So it tends to be a very good indication for anti-VEGF agents, although obviously not everyone has them. So with laser treatment, obviously the pros are that it's one treatment. So if it's done correctly, and it does take a lot of skill and practice to become good at ROP lasers. I think they're the hardest laser that you can do. There's a decreased need for follow-up, and it's more permanent, meaning that the retinopathy of prematurity regresses after one, sometimes two sessions, and then you are able to not follow the infants as closely, and they depending on where the parents live, if they live close to your center or they live far away from your center, that can obviously play a role. Social situations can as well. If you don't think the infants are going to be brought to follow up, then laser is a much more kind of durable and permanent option, obviously. The cons being that it can take 2 weeks to demonstrate effect. You can have cataract formation, glaucoma, anterior segment ischemia, retinal tears or detachments, treatment failures. So not all centers do this. At Children's, we tend to intubate and sedate these babies, and then obviously it's a fairly difficult procedure, especially in situations like in the past slide where it was in zone 1 and there was very active ROP to cover the entire retina. But it can become very important because it cuts down on the need for follow-up depending on that. And obviously we want the babies to be as safe as possible, even if we can't see them. Anti-VEGF injection, the way I think about it is it's much easier up front. So whereas a laser is much easier after the laser is done and the ROP is regressed, an anti-VEGF injection is much easier up front. So you um, an injection obviously takes a minute. It generally does not need sedation. What we found is in the older babies who are bigger, sometimes they do need a little bit of kind of either intranasal Versed or oral lorazepam just to relax a little bit, so they don't bear down as much when we're doing the injection and risk pushing the medicine out of their eye. It obviously takes rapid effect, so you don't have to wait for the 2 weeks for the um, laser to take effect, and it continues to let the retina grow afterwards. The cons, similar to laser in the sense that you could nick the lens and cause cataract formation. You can have increased pressure afterwards. This tends to be associated with the volume of liquid that you inject. So most of our injections are either in zero point zero 0.01 or zero point zero 0.02 cc's. There have been some studies that have shown that 0.025 cc's or higher is associated with higher risks of raised intraocular pressure. You can get retinal tears or detachments depending on the needle that you use. So one of the things that we have adopted is the safer protocol for injections. So we use a 32 gauge needle. We sterilize the eye with 5% betadine. We have close follow-up for these kids. So after injection, we will see them within 24 to 36 hours to assess for infection. And then if it's around 36 hours, a lot of times we can see improvement already and then can follow them a couple of days later just to make sure that no late infection develops. Or if it's 24 hours and we haven't seen improvement yet, then we'll continue to follow them until there is improvement. From the ROP1 study, treatment failures on the initial injection were called at approximately post-op day 4. So that's kind of, you really want to see improvement by post-op day 4. There is an unknown effect on development. So we are injecting anti-VEGF agents into very small children, and we obviously are injecting less quantities of it now than we had in the past. But it's a really hard patient population to kind of assess for development because they obviously have a lot of developmental issues related to their other comorbidities. And there is a level of systemic VEGF suppression, which is thought to be less in our newer agents. And then there can be late recurrences. So this is where I was kind of referring to in that you will the work up front is easier for an injection, technically, but then you're following these babies for long periods of time to see if they will recur. The most recent data from the Firefly Next study, which is published in 2026 in Neonatology, is that babies who didn't have a recurrence with aflibercept by 50 weeks did not have a recurrence up to 3 years, which is where their study data is right now. But there are case reports in the literature of 6-year-olds and older patients developing kind of recurrences and not fully vascularizing. And so at Children's, we take all of these children. This is also part of the safer protocol for an exam under anesthesia with fluorescein angiography around a year of life, or earlier if they're going for another procedure to perform laser to the avascular retina that still exists. And then what I tell families is we usually have to do about a third the amount of laser as we would have had to do in a primary situation. And this again is I usually use when I can no longer examine them in the office as the time for to start considering it because I really want to know what's going on in the back of their eye and I don't want to miss anything. But you can imagine how these fairly sick children also have other doctor's appointments and they're going to lots of doctor's appointments. And they also need to remember to come to their eye appointment every 1 to 2 weeks or sometimes a little bit longer depending how old they are. And that can be very challenging. And so current issues with anti-VEGF agents. So following the BEAT ROP study, PDIG ROP1 tested de-escalating doses of bevacizumab to test its efficacy and systemic safety. The study enrolled patients from 2017 through 2019. It included premature infants with type 1 ROP in at least one eye. The intervention was low-dose bevacizumab intravitreally, either 0.25, 0.125, 0.063, or 0.031 milligrams versus very low dose, which was 0.016, 0.008, 0.004, and 0.002, with a higher dose in the fellow eye if both eyes were treated with anti-VEGF agents. And this specifically was bevacizumab. At 12 months, both study eyes and fellow eyes received treatment at similar rates. So even though it was lower and lower doses, both were seen to be effective. Core structural outcomes were low in both eyes, and there was really no difference in rate of reactivation, though there was a tend towards shorter time to reactivation in the very low dose intravitreal bevacizumab arm. And so this is usually between 10 and 12 weeks with Avastin or a bevacizumab. With ranibizumab or Lucentis, which was covered in the Rainbow trial, it was also shown to be effective and not inferior to uh, laser. The what has been noticed in our personal experience and in the studies have been that ranibizumab has a typically higher rate of recurrence because it tends to leave their system faster, which is both a good thing and a bad thing. It's a good thing because it leaves their system faster, but it's a bad thing because we don't really want to be dealing with ROP recurrences. And then, of course, not every ROP recurrence it requires treatment. Sometimes they just recur and then you watch them and then it self-resolves. It doesn't become type 1 again. And then finally, aflibercept or Firefly or Butterfly, which was in 2019. And as I mentioned, the Firefly trial, which was done in Europe and Russia, led to the Federal Drug Administration approval of its use in the United States for retinopathy of prematurity. And it so all of these agents are used now in the United States, and I think with varying kind of depending on what center you're at, they all can be very effective. And it's just very important to know what the kind of half-life of the drug that you're using is, because you need to know when the recurrence might happen and how closely to watch. Finally, on the horizon, there was recently a study published in the Journal of Ophthalmology about using dexamethasone 0.1% eye drops in the prevention of type 1 retinopathy of prematurity. So when you look at animal models of oxygen-induced retinopathy, if you administer dexamethasone drops prior to the peak neovascularization, so around type 2 retinopathy, it significantly decreased the burden and progression of it. And so the thought was this could be a minimally invasive way that we could help prevent retinopathy of prematurity progression. The Grants et al. Published a recent retrospective review. This is the study in ophthalmology during two time periods, the 2015 to 2018 time period and the 2020 to 2021 time period, where they were using dexamethasone drops, and the initial one, 2015 to 2018, when they were not. So as I mentioned, type 2 ROP got one drop every day when there was stage 3 in zone 2. It was every other day if it was stage 1 to 2 in zone 1 with no plus disease, but eventually would require one drop every day because it would progress. In rare advanced cases of type 2 with pre-plus disease, sometimes twice a day drops were used, but the goal was to decrease that as soon as possible, and then to taper it off when there was no longer type 2 ROP present. And if you look at their graphs, it's actually quite dramatic. In terms of interventions that they've had to do, and in terms of the number of screened infants that required treatment, they both really went down significantly. Obviously, there are some risks that haven't really necessarily been well elucidated because this was not like a clinical trial. This was a retrospective study. And so the systemic exposure is theorized to be very small. The infant eye can only hold about a fifth of a drop. Punctal occlusion was used. No patients developed adrenal suppression, although it's unclear how many were concomitantly given systemic steroids for this problem, for BPD, sorry. And then ocular side effects, cataract formation, steroid-induced glaucoma were not observed, but are, again, important to consider. And then finally, something that has been a developing problem for our institution is now these nano premature infants, these under 24 weekers and under 600-gram infants that are being born. And we published a paper in the American Journal of Ophthalmology about their long-term outcomes. And what we noticed is kind of what you'd expect, that a more significant number of them required treatment. If you look at some of the national studies, nano premature infants typically about 50 to 60% of them will go on to require retinopathy of prematurity treatment. The treatment age is younger in these kids. They're more at risk for having more posterior disease. Interestingly enough, long-term effects, there was no difference between them and micro premature infants, which are 24 to 26 weekers. Both groups, though, had spherical equivalents of one or less at 4 years for those who we still had follow-up for. And obviously, in these kids, you are going to expect them to be more myopic. In a 4-year-old, you'd expect them to be more hyperopic than a +1 spherical equivalent. So there definitely is a trend towards myopia. So that was my talk. So it was a whirlwind tour through retinopathy of prematurity. And I hope you guys enjoyed it. And I'm going to take questions now. So the first question, is gene therapy possible? I think the answer is in cases where there are something called ropers or ROP kind of extended spectrum, meaning some of these children actually may have worse ROP because they have an underlying fever or some other genetic condition. I think that those could be targeted for this, but unfortunately, there's at least not yet has there been elucidated some genes that we can target for this, and I think a lot of it has to do with how these infants are cared for and how their clinical course goes, and that can be very hard to determine going further. Um, the next question is, if a child already has a stage 5 retinal detachment, is it possible to get treatment? The answer is yes. You can treat stage 5 retinal detachments. They are extremely hard to treat, and the visual outcomes are generally very poor. But there are some very skilled retina surgeons who specialize in pediatric retina and retinopathy of prematurity who can try, but the chances of having a good outcome are very small. The role of the optometrist in screening was one question. And so I think that it's very hard. I think it depends on your area and level of expertise. In the United States, optometrists typically do not screen for retinopathy of prematurity because the level of acuity. But in that may be different in other more resource poor settings. I think this really is the role of the ophthalmologist. In your experience, how can clinicians optimize examinations of older uncooperative infants while minimizing the need for exam under anesthesia? I think this is a great question. I think it all comes down to just like in surgery, your assistant. I typically, when seeing outpatients, have one of our nurses who is a NICU nurse as well. We have two on our staff. Obviously, not that's not available for everyone, but I think if you have a very good technician who is used to holding babies. I think having someone who's skilled and experienced in holding the children is very helpful. Swaddling is also very important. So for the larger babies, we will, even the bigger ones, we'll just get a bigger blanket and we will swaddle them, which can be very helpful. And then sugar water can be very helpful as well, and a pacifier. So those are my kind of big tips as to what I do. Also, as you get older and more experienced yourself, the other maneuver that I use that I was taught was the doll's eye. So the less you have to use your depressor, the better. And if you doll's eye, you can kind of get the eye into a different position, and oftentimes they'll bells or look in the direction that you want, and you just kind of have to use their moving to help you out. Another question we have is, for older babies, why not IVI before laser? Um, that's a great question. It all depends on the baby itself. So if a baby is sicker and will not tolerate a laser, that's a reason to do an intravitreal injection. Um, if a baby is older and has grown further out to kind of near a degree where we would see had they been younger and we had injected them, then if we have the ability to do the laser and cut down on the need for follow-ups and the outcomes would be similar, then we would consider laser. As I mentioned, or I hope I mentioned, it's very baby specific. But if we can do a laser and kind of save the degree of follow-ups, and there really won't be much different than doing an intravitreal injection before then, you might be kind of kicking the can down the road. Also, depending on the level of neovascularization, there is always the risk of the anti-VEGF crunch that you can see in diabetics who have tractional retinal detachments, things like that. So as what it's describing is when you give the anti-VEGF agent, you the stage three or neovascularization regresses so quickly that it can cause traction. It has been seen. It's definitely been seen in diabetics more so, but it's just one of the things that we think about in these older babies. Also, as I mentioned, older babies can be a little bit harder to inject. They can bear down, and I've seen them unfortunately squirt the medicine out of the tract just by bearing down. So there are things to consider, but those are the big ones. The next question is how many intravitreal injections, and it very much depends. So babies who are these nano premature infants that we have seen often have been the ones who have required more than one intravitreal injection. And it's we theorize that it's because they're so young and they just have such active VEGF levels for so long. Um, you once we treat them once, the second time we treat them again, we go through this idea of, would a laser be more feasible? Would a laser cut down on follow-ups, depending on where they are? Some of these nano premature infants remain in zone one after their first injection and then develop a recurrence of type 1 ROP while still in zone one. And obviously we would treat them with an injection. So again, it becomes an area where you have to be very personalized to the patient. Our choice. So the next question is, what is the choice of intravitreal drug agent, and what is the dosage and site of injection from the limbus? So our current choice is aflibercept because it has been approved by the Federal Drug Administration in the United States. That's why we've been using it. We've had good success with it. Its dosage is zero point 0.4 milligrams per 0.01 mLs, which is about a fifth, I believe, of the adult's dose. Um, we like it because it comes in a prepackaged syringe. And so therefore theoretically reduces the risk of infection. And then our site of injection is usually 1 millimeter from the limbus. So you have to remember when you're injecting in an infant's eye, the lens takes up a significant portion of the eye itself. So you're injecting straight down rather than injecting towards the nerve like you would do in an adult, and you're very close to the limbus with the goal of not hitting the lens. Um, uh, the next question is about telescreening. How do you balance the improved access to care provided by telescreening against the risk of missing peripheral retinal findings that might indicate the need for treatment or closer follow-up, especially in older infants who are harder to image? This is a great question. I think that the the answer is twofold. One is the NICU teams that are doing our telescreening, so the nurses and nurse practitioners that are doing this in all the NICUs, they tend to improve over time. So their ability to get further and further out is really quite impressive. And then the other thing I would say is that most peripheral findings that indicate a need for treatment, you can see more centrally that there is something going on that would indicate the need for an in-person exam. So if the vessels start to change in an older child, start to look a little bit more like plus disease, start to just you can kind of see as they go out if they're getting more tortuous and dilated to suspect that there is active retinopathy. When you go further out, one of the things I tell our fellows when they're learning to do in-person exams is to follow the vessels. And if the vessels start to look weird or funny or dilated, tortuous, and you don't see ROP, you're missing it. And so I feel like on telescreening, what I've noticed is you can do the same. So I think that some care in a lot of instances is better than none. I think that our experience with telescreening has been great because of our ability to get good pictures. I think that the chances of missing peripheral findings are much smaller uh, than you would think. So the next question was from a provider in Colombia who is in a rural practice, and wanted to know how often premature and pediatric patients should be referred to an ophthalmologist after NICU discharge. Um, they're usually less sick in this patient setting. So for pediatric ophthalmology follow-up, our usual protocol is to see them until their retinopathy of prematurity has resolved, and then do a repeat exam around 9 to 12 months, looking at their refraction, looking at their so need for glasses, development of amblyopia, and then if they look good on that exam, they have a normal refraction, then to discharge them to the regular screening that goes on. Um, the next question is about Vabysmo. I'm not aware of any of Vabysmo trials for retinopathy of prematurity specifically. Vabysmo, to my knowledge, is a high dose anti-VEGF inhibitor of aflibercept. I think, sorry, I'm not an adult retina provider, but we don't use that. We just use the regular aflibercept or Eylea for this. Obviously, we want to keep doses smaller because they're younger babies, and so that the trend has been towards less concentrated um, and lower dose agents. Um, how long do you follow babies who have received only an anti-VEGF injection? So as I kind of mentioned, our protocol in at Children's is that when they've had an anti-VEGF injection, we follow them until they go for their exam under anesthesia and then have laser. And then I will continue to follow them after the laser for the PAR or peripheral avascular retina, but this is very specific to anti-VEGF injected babies. And then I'll usually see them once or twice a year from then on, just to monitor for changes. I think it's really important that any baby who's been injected with an anti-VEGF agent then have lifelong follow-up in retinopathy of prematurity. There was another question about Vabysmo. So it does look like it's a different antibody. It's not any that one that I typically use. I know it's big in the adult retina world. So I think I guess it does not look like it is a aflibercept. It's something else. So I would say that we don't use it yet. Um, do you always perform laser, even if they are stabilized prophylactically at a later stage for babies only treated with anti-VEGF? The answer is yes, but it's much later, right? So it's at about a year of life. So post 60 to 70 weeks gestation or later. It very much becomes when I can no longer examine them in the office. It's part of that safer protocol, which was written by a number of ROP experts, and I highly recommend people checking out that they recommended in their protocol after 60 to 65 weeks, I believe, taking them for an exam under anesthesia. It's very interesting when you do that and you do a fluorescein angiogram, you can often see leakage and even sometimes active retinopathy of prematurity as much as a year later when we're doing it. And then the case reports of later activations are enough to make us want to make sure that we can do as best as we can to prevent that from happening. Um, there's a question on dexamethasone. What are the side effects of dexamethasone? So in the treatment trial, or I should say, retrospective cohort study that was published in ophthalmology, there were no side effects that were noted. But obviously, any steroid eye drop, you can have ocular hypertension, steroid-induced ocular hypertension, or glaucoma. You can have cataract formation if they're on it for too long. The theorization of the systemic cortisol suppression is another one that's important, although with punctal occlusion, the risks of it are very, very low. Um, so those are the major side effects. We have another question about managing late recurrence after anti-VEGF and ROP. So monitoring them, we continue to monitor them as we would any other ROP patient. So we watch until they're completely vascularized, or we take them for an exam under anesthesia. In terms of management of it, so a recurrence is one thing. You can develop a recurrence and it can be stage one retinopathy. You can develop a recurrence and it can be type 1 ROP, in which case it would get a repeat treatment, either laser or injection. If it's late, it's usually laser because they've already grown out so much. But so in terms of monitoring, I usually follow these patients every 1 to 2 weeks until you get through that time frame when they can recur, which again is depending on the agent you use, around 8 to 12 weeks or so. I think 10 is kind of the sweet spot for bevacizumab and aflibercept. And it can and then and then I will space it to every 2 weeks, and then as they get older, sometimes even more, until I can't examine them anymore. Um, which anti-VEGF agent, bevacizumab, ranibizumab, or aflibercept, is currently recommended? I think that there are differences across regions, even in the United States. I don't think there is one that has necessarily been deemed to be better than another. I think that it depends on what is the easiest for you to get access to. Obviously, ranibizumab and aflibercept can be much more expensive. The and then there are other kind of risks and benefits, pre-filled syringes versus not, versus compounding. In terms of bevacizumab, what dose can you give? Our pharmacists, since they were involved in the ROP1 study, are comfortable giving us lower dose bevacizumab. I know there are other institutions where they're still using the half dose bevacizumab from the BEAT ROP study. I think it just depends on where you are, but I don't think one is necessarily superior than the others. The only thing that I tend to think about is with ranibizumab, there is a fairly high rate of recurrence. So it's just something that, as long as you're aware that it happens, to watch out for. It has its benefits too, in that it leaves their system so quickly. So I think that's important to just know the agent that you have, but I don't think one is necessarily recommended above the others right now. Another question, when to consider failure of anti-VEGF and when to re-inject. So I go back to the ROP1 study and some of the other studies, and that it's around 4 days. I think if you have not seen a significant improvement by 4 days, then you need to consider something else. One of the things one of my mentors, Dr. Deb Vanderveen, taught me was you also have to remember the kind of the how quickly ROP is not going to get worse, in the sense that back before anti-VEGF agents existed, these babies would be lasered and they'd have to wait 2 weeks to see a result. Anti-VEGF agents have kind of followed along with the rest of us in the world, and made us a little bit more impatient to see results. So at 4 days, if you really haven't seen an improvement, that's when I would consider re-injecting. It's extremely rare. I think in the last 5 years, I've had one baby require a re-injection like this. And that child, interestingly enough, got injections in both eyes, was a 23-weeker. One eye failed after 4 days or never really succeeded, and so required re-injection. And this was with bevacizumab, 0.25 milligrams. And then the other eye actually failed within about a month. So there's something, I think, also about that patient. These children are very sick and very young, and obviously very different. Um, This is a great question. What is the role of the pediatrician in ROP prevention? It's such a team effort. Some of my favorite colleagues are our NICU providers, because of the amazing care that they take care that they provide the babies. These children are so vulnerable and so sick. I think it's such a important thing to discuss with the NICU in terms of how concerned we are about their eyes. What level of retinopathy they have. Is it progressing? Is it getting worse? Talk about their oxygen levels, their lung status. The pediatricians can really inform us on how sick these children are, and we can inform them on how sick their eyes are. So I think the role is that it's a team effort, and that we couldn't do what we do without the excellent care that the neonatologists provide. Can babies who have been intubated for a long time develop this disease? The answer is unfortunately yes. It's often those who are intubated for a long time have worse lung function, more bronchopulmonary dysplasia, and there's definitely a link between those two. Obviously, the inability to oxygenate the retina is a problem. So these are babies who we need to watch very, very carefully. How long, another question about dexamethasone drops, which is a great question. How long would the dexamethasone drops be given for? Usually it's under 4 weeks. A lot of times it's 2 weeks. I highly recommend checking out that paper. I believe it's free on PubMed, and it can give you a protocol for using it. But the goal is for a short amount of time. Um, Next question is if bilateral type 1 ROP, when we inject, when do you inject the other eye? Do you wait a week or not? We generally do simultaneous injections for both eyes. We prep the field as a sterile field. It's essentially an operating room in the NICU, and the so we have two separate sets of equipment and two separate sets of gloves. So we treat them as two separate procedures. We prep both eyes individually when we do them. I would generally not wait a week for type 1 ROP in any eye. The treatment protocol in the United States is that it needs to be treated within 24 to 48 hours of discovery. If you wanted to wait a day and inject the next day, I think that's could be a reasonable decision depending on your rates of infection. Unfortunately, in my practice, they are quite low, but they can happen. It also depends on what you thought has caused the infection. I think another important to point out is one of the major drivers of endophthalmitis from intravitreal injections in adults is oral flora. And so babies who are on CPAP, if the CPAP, we try to have them have the nasal prongs in if they're on positive pressure ventilation, because we don't want the air to be blown, the dirty air from the nose and mouth to be blown up towards the eye, as that can cause an infection. I think there have been case reports of that as well. So with that, I hope that I helped, and I think we're going to wrap up for today. I really appreciate everyone coming and would and love talking about ROP.